Okay, we did a very nice case. I performed all of the things that I want to do. And I want to summarize what we did, and I want to show you what's our procedure, how we do it. So this is the bladder, this is the ureteric orifices. There are 2 ureteric orifices. So embryologically, I believe the tissues in the urethra, and it opens to vagina, okay? And we know that nearly half of this urethra has a different epithelium, squamous, and then half of it has uroepithelium. We call it transitional. And the bladder also have transitional epithelium. So we believe all of these epithelium is same, and it changes to outside squamous vaginal epithelium in that part. So I noticed that all of the chronic infections are settled in the bladder neck and trigone. Trigone is this area between the ureteric orifices and between the urethral orifice. There is a triangular area. I always see the leukoplakia tissues in that area. So I think this area is embryologically different. When I fulgurate these tissue, newly coming tissues are coming from the side walls, and they are the same transitional epithelium like these side walls. And they all cover, when I fulgurate these, okay, so they all unite together, and all of them are transitional now. And the infection becomes, the tissue is infection resistant.
Yes.
So after noticing this, I was fulgurating this part, and it was healing. 80% of the patients healed, but still there was a 20%. And most of them was saying, we have urethral pain, urethral irritation, and I was saying I cannot touch the urethra. So I can only fulgurate the bladder. Urethral epithelium is different, we can't touch. It stays closed normally. If we make a fulguration there, it will stick onto itself, and this is not possible. Then I noticed in a patient that we were missing a part of the urethra in our previous operation. I couldn't understand it first. It was very strange. I make a flexible cystoscopy to this lady, and there was a missing tissue, red tissue. We said, okay, there is the inflammation. Next day, we take her to the operating room, but this tissue was not visible. We couldn't see the tissue. So we take the flexible cystoscope into the operating room, and when we look with the flexible, we see it. But with normal rigid instruments, it is invisible. So I noticed something, and I made a theory. Let me show it to you. So this is bladder. It's a sagittal view. Sagittal means the body is cut. The body is cut like this, and we are looking from the side. So this is a sagittal view of the bladder and urethra. Urethra is like this curved shape, and when we go in with the flexible instrument, this instrument is like this. It go inside, and it takes the shape of the urethra, and it can turn, bend on itself, and it can see from upside down. So we were noticing there are some tissue here missing. We couldn't fulgurate this area. Then I noticed that it is happening like this. Okay, with the flexible, I draw it again. This is the missing part, and we want to fulgurate this area. But when we go inside with the rigid instrument, we straightened this urethra. And look, this is 5 centimeters. This larger curve is 5 centimeters, but the inner curve is like 3 centimeters, okay? Because it is in the inside, the curves are different. So when we go with the rigid instrument, let me draw it again.
Okay.
Okay, when we go in with the rigid instrument, it is a thicker instrument, and this part of the bladder, as this part, the upper part now is 3 centimeters urethra, and the lower part is 5 centimeter urethra. When it is straight, the 2 centimeter part of the bladder moves into the urethra. Okay, like this is 2 centimeter part moves into urethra, and when we look with the camera, we think that this is urethra and we don't touch this part. So we move inside and fulgurate the tissues here, the leukoplakias here, and in the bladder neck. We all make this part, but we are always missing some part. So now we change our procedure. Now we go in with the flexible instrument first, and it shows us all the leukoplakia tissues in the trigone and in the bladder neck correctly, and they are just as this red, very red, inflamed areas. Okay, we see the bladder like this, and urethra is now here like this. We are inside with the flexible instrument and looking at the flexible upside down. Okay, and then when we go with the rigid one, we know that some part of the urethra is, bladder is moving into the urethra, and as it becomes like this, we make a mark here because with the flexible instrument we cannot do any operation, anything. It is just for looking. So we put a mark here, and we put the borders of the inflamed tissue, and then we go again with the flexible and check if these marks are placed correctly in the bladder neck. So we start the resection, fulguration from here. This was the part that we think it was normally urethra, but it's not urethra, it's bladder. So we start the resection from here, and then at the end we control with the flexible again. And by this way, we think the results are better, and we try to improve our technique every time, every day. We are on this subject. We are a big group, big family, and try to improve our technique, everything. I think I have to define it more clearly in the future. Thank you.